Good morning, everyone. Let's say if there were 100 people in this room, then 12 of them have diabetes. More than half of them don't even know about it. To make things worse, 2 of them are going to die because of it. Could something be done to prevent all of this? Let's have a look. Hello, respected chairpersons, esteemed listeners, and everyone present here. My name is Dr. Jitesh Satija, and I'm going to tell you about one such strategy called IDRS in my research titled Validation of the Indian Diabetes Risk Score as a Screening Tool for Undiagnosed Type 2 Diabetes Mellitus, a study from North India. We'll begin with the introduction. IDRS is an efficient screening tool devised by the Madras Diabetes Research Foundation in the year 2005, which helps to detect high-risk individuals based on simple anthropometric and demographic variables. We all know Indian people characteristically have increased insulin resistance, higher prevalence of impaired glucose tolerance, higher waist circumference, despite lower body mass index, that is abdominal obesity. The references are cited below. Studies have determined this IDRS scale has the sensitivity and specificity ranging between statistically significant ranges. We all know over 1 in 2 adults living with diabetes are undiagnosed. This is shocking. Slide changer is not working.
Use the changer on the. You can see that it's moving.
Yeah.
It's fine.
I guess it's lagging a bit, no problem. I'll make up for it.
Next.
Yeah. The aims and objectives of my study were to validate IDRS screening tool by using confirmatory tests for diabetes by estimating HbA1c levels, to use IDRS to identify adults more than or equal to 30 years who were at risk of developing type 2 diabetes. The methodology employed was a community-based cross-sectional survey. There are 4 primary health centers in Rohtak which cater to a population of 80,000 each. Using the best method for sampling, that is simple random sampling, UPHC Ekta colony was selected, which caters to a population of more than 86,000 and more than 17,000 houses are situated. The inclusion criteria was individuals more than or equal to 30 years who were never diagnosed with diabetes earlier were included in the study and were permanent residents for more than or equal to 1 year. Patients living with diabetes or suffering from any other chronic illness were excluded. Severely ill, bedridden, pregnant, and lactating women up to 12 weeks postpartum were also excluded in our study. The sample size was calculated using 95% confidence limits, 20% relative precision, and the lowest possible prevalence of undiagnosed diabetes in literature, that is 12.85%. The study is cited below. The sample size was calculated to be 679. We enrolled more than that, that is 700 subjects, and after excluding the incomplete forms, a total of 686 forms were analyzed. For each household, numerical ID was created, and a random number was generated using SPSS software. House-to-house visits were done after taking written informed consent from the participants. Based on IDRS criteria, the following data was collected, that is age, family history, level of physical activity graded as per the WHO criteria, waist circumference, hip circumference, and blood pressure. HbA1c was estimated using HPLC, that's high performance liquid chromatography method. High risk cases more than or equal to 60, moderate between 30 to 50, and less than 30 were no risk. The physical activity was graded as per the WHO STEPS criteria cited below. Statistical analysis was done using SPSS version 24 and MS Excel. This is the IDRS score, the variables listed on the left side and the scores simultaneously. In the results, this is the basic anthropometric parameters showing all the variables along with their mean and standard deviation. This shows the association between IDRS high score that is more than equal to 60 along with HbA1c cutoff 6.5 based on the diagnosis that was found to be statistically significant using chi-square test. Distribution and association of IDRS score according to age, gender and BMI is shown in this table. The IDRS is classified into low, moderate and high. This is an ROC, receiver operated curve was shown. We can see the area under the curve is maximum under the value 70, but the sensitivity of the test, which is the main criteria of any screening test, decreased from 88 to around 66. So 60 is the cutoff value that should be taken. These two are the same tables which describe the ROC curve further. Now, in the discussion part, we know IDRS is a simple tool which can be used to decrease mortality and morbidity by screening the patients. And I would conclude by saying that high-risk cases from community setting can be screened by this. Hospital can have pilot teams for this, for decreasing mortality and morbidity. Thank you, ladies and gentlemen.
Dr. Satija, what is your IDRS score? Have you ever calculated your own?
Yes, absolutely.
What is your IDRS?
Mine is below 30.
It is below 30.
Yes.
So is it helping in any way in reducing, like you are a community medicine person, you go into the field and you want to screen a community.
Yes.
How is this going to help you? Is it helping you exclude patients who need not be screened, or is it helping you include the patients who need to be screened?
The latter part, sir. It is helping me to screen the high-risk individuals so that we can provide them early care.
So you said high risk is more than 60.
Yeah, the cutoff value using the ROC curve.
So what is the percentage of patients who turned out to have diabetes, those who had a risk score over 60?
Yeah. In my study, there have been several studies. The IDF
in your study, those who are above 60, how many of them turned out to have diabetes, undiagnosed diabetes?
Undiagnosed. The sensitivity of the test is
not sensitivity, just in numbers.
Yes.
What percentage of patients who had IDRS over 60 turned out to have diabetes?
Roughly around 90%.
90%? No, not according to your data.
That's too much. I think you are. It's not. I'm not talking about sensitivity.
Okay.
If you have a screening test that is so good that 90% then you don't even need to do an HbA1c.
Okay.
So that will be
the positive trajectory. Yeah.
So what is in your study, those who had more than 60, score of more than 60, what percentage turned out to have HbA1c more than 6.5?
More than 6.5. I cannot recollect right now. I have it in the table. But what I know is the prevalence of undiagnosed diabetes in my study turned out to be around 25%. The undiagnosed people. That was really shocking to me. And I feel that it is high time that tertiary care hospitals start having pilot teams
You said that you want to use this as a screening test, right? Rather than ruling out patients who need to be screened. You want to pick up patients who you would like to screen for diabetes.
Yeah, because this is a quick test.
So what would be a good cutoff based on your sensitivity table? Do you want to stick to 60, or do you want to change that value to improve the sensitivity? If your aim is to screen maximum number of people,
yes,
you want to increase your sensitivity.
No, see, if I am supposed to increase the number of participants who are at high risk.
Based on the data you have.
Based on the data, the thing is the exact value, which when we say sensitivity and specificity, that is the main difference between both of them. Is sensitivity would help me make out if a person is positive and call it a positive. The specificity would help me if someone is negative, it would call it a negative. So 60 is what I would prefer.
What was the sensitivity at 50?
Sensitivity at 50. Sensitivity at 50 is less than what at 60.
It will increase, no?
Huh?
It will increase.
Okay.
It's okay. It's getting very confused.
You have compared with any other available score, clinical score for in this study, comparing with any other available score, and what improvement you think can be made?
Yes. See, so being in the field, I feel the test should be very simple, because the field teams, the ANMs, the MPSW should be able to carry out these tests. Personally, I have, there is a Finnish score, there are other scores, and currently at PGIMS Rohtak, I am personally doing a study using bioelectrical impedance assay to rule out, to detect high-risk cases who have higher levels of fat in their body, higher levels of visceral fat to be precise. So,
just in clinical parameters to predict diabetes, can you improve upon whatever is available right now? Any idea, any perspective on this?
I'll ask you a simple question. How did you measure waist circumference? What did you tell your, I mean, they must have measured a lot of waist circumference,
yeah,
700 waist circumference.
Yes.
So how did they measure it?
The measurement is from the bony prominences, and then we measure around when we calculate for the visceral obesity, we take the maximum around the waist.
So
and it is a non-stretchable tape.
Did you give them a guideline? This is how you have to measure. In your methodology, did you define this is how you are going to measure the waist circumference?
Yes. There is certainly a guideline. There are.
So what was your methodology that you gave to your staff when they were measuring waist circumference?
Yeah, the measuring tapes were provided. They were non-stretchable to a precision of 0.1 centimeter.
Okay.
And the person should be standing erect.
Okay.
And the maximum waist circumference should be taken. That is around the bony prominences, where they tie their belts. That is to be taken.
Women would have completely different. No, so you have. I mean, you did not give them an exact location where they will check for the waist circumference.
Yeah, but we have trained staff. I gave it to them. They did that.
Your trained staff will be well trained, but if I ask my MD residents to do it, they will not be able to do a right waist circumference unless you train them specifically for that.
Yeah.
Okay, thank you.
Yeah, thank you so much.